Okay, this is the fifth session on COVID-19 pandemic, and we're going to look at two different controversies today. Firstly, the sensitivity and specificity of the various SARS-CoV-2 tests, and then secondly, we're going to look at vaccines, asking the question, how do they work, and more importantly, will they work? So the first thing I want you to do to answer the first question is read the following article. It can be accessed by this link here, but it might not work. So what I've done is I've put the full text of the article on this slide here. And this is an article from The Spectator written by Professor Carl Hennigan from Oxford Centre for Evidence-Based Medicine. So read through it and read through the scenario that has been set here and read through it again, make some notes, and then write down your thoughts on the point that is being made. So that article discusses sensitivity and specificity, two very important features of any diagnostic test. And sensitivity is reflecting what percent of positive cases are detected by a test. So if you want to try to detect everybody who is SARS-CoV-2 positive, you would want a test that is 100% sensitive. Now, sensitivity always comes with negative aspect of it, which is its effects on specificity. And specificity reflects how many positive tests are indeed true positives. And this is really affected by negative patients receiving a positive test. Now, clearly that shouldn't happen, but it does happen, and it can happen in two different ways. One, it could be that the disease marker that we are detecting, in this case viral RNA and viral DNA, does not always associate with disease or even with infectious disease. So you could have somebody who is SARS-CoV-2 positive who is unwell, so they will be symptomatic, and that was a positive, a true positive. You could have somebody who has the virus who is not unwell. They could be asymptomatic. They could still be infectious. Now, is that a false positive? Because it's a false positive for the disease, but it's not a false positive for the infection. Equally, you could have somebody who is free from obvious signs of disease, so asymptomatic, and also has very low levels of virus because their immune system is rapidly clearing it, and they may have such low levels of virus that they are non-infectious. So the test is detecting the presence of viral RNA, but the person is not diseased and might not be infectious. And this could be classed as a false positive. So these false positives could be this problem, the disease marker not associating with whatever you define disease. Or it could be that the biochemical assay is just not detecting the virus as you would want it to. And this can happen if the PCR primers cross-react with another virus. That doesn't happen. Or it could be, if it's antibody-based, it could be that the antibody that you're using is cross-reacting with another closely related virus. That certainly can happen. And when we're discussing sensitivity and specificity, we look at graphs like this, where we've got a number of persons here. So this is a graph of individual data points, like a normal distribution. And along this scale is usually some readout. It could be, if it's not COVID related, imagine hemoglobin levels, and you're healthy, have got a certain hemoglobin level, and you're diseased, have got a different hemoglobin level, and at some point there's a cut-off between someone who's anemic and somebody who's not. So this axis along here could be a continuous feature such as hemoglobin levels if you're dealing with anemia. When we're dealing with SARS-CoV-2, we're dealing with a test which is binary. It's either yes or no. It's either positive or negative. And the cut-off value for most of the PCR tests is 40 cycles of amplification, which should be enough to detect one single virus particle. And if you are negative, after 40 cycles of amplification by polymerase chain reaction, if you are a true negative, that test should come up negative, and if you're positive, there should be a positive signal before 40 cycles of amplification. So the problem comes with having healthy individuals who have got no presence of virus coming up with a positive test. Now that can happen due to cross-contamination of samples, and we'd call that a false positive. It could be that for one of the reasons down here that the assay just doesn't work particularly well, and we'll call that a false positive. It could be that the person is diseased, so should be positive, but comes up with a false negative result. And that could be the patient didn't swab themselves properly. It could be that the virus levels are below the limit of detection. So that would be a false negative. So the person has the virus, it is not detected by the test, is a false negative, or the person is healthy, doesn't have the virus, but comes back with a positive test. And you'll see we've put the cutoff value so that we maximize our sensitivity, so we get as many of these diseased individuals as possible without giving a false positive diagnosis to a whole load of otherwise healthy people. So the cutoff value often sits where these two distributions intersect. And that results in the maximum possible sensitivity whilst keeping the maximum positive specificity without particularly affecting either group, well, by affecting either healthy or diseased group as little as possible. So sensitivity and specificity is a real problem in screening, particularly where the frequency of a positive test is quite rare within the population. So if the false positive rate is 1 in 100 and the frequency of a genuine positive is 1 in 100, you would test 100 people, you would pick up 1 false positive and 1 genuine positive. Therefore, half of all positive tests are false positives. Now, the article by Hennigan here describes a similar situation, and if you read through it, it will talk about, imagine testing 10,000 random people with an infection level of 0.1%. It talks about how many people will be tested positive, how many will be negative, and then if we know the sensitivity of the test, then we can work out how many people should return a positive test, how many people will return a negative test, and how many of those test results are correct. Now, mathematically, this article is absolutely fine. There is no issue there. What is not necessarily fitting with the current state is, firstly, the positivity rate in the population. This article doesn't reflect that, but it also doesn't reflect what we know about the false positive rate of the assay. So the article here talks about scenarios where the specificity of the PCR test could be as low as 95%. Now, this was back in the summer of last year, of 2020, and what we do know now is that the specificity of those tests is much, much higher than what was described in this article. And what you might want to do is, how would you test the specificity of a test? What would you need to do to be able to test the specificity of a test? Now, the problem is, a test such as this has been brought out whilst people are significantly affected by this virus. And what you need to test if the test has a specificity of greater than 99.999% is you need 100,000 genuinely negative samples. You need to test them all, and they should all come out as negative. And that's a very difficult thing to do when the prevalence of the virus in the population might be as high as 2% in the worst areas, and might be as low as 0.1% in the summer in certain areas. So it's a very difficult thing to do, but it's not impossible. So let's go through this scenario. 10,000 people have a test, the false positive rate is 0.1%, and let's say the prevalence in the population is 1 in 1,000, which it was earlier this year. So in that situation, there are 10 false positives. If 1 in 1,000 are genuinely positive, then 10 in 10,000 will be positive, and there will be 10 true positives. So in this scenario here, false positives and true positives are the same. So this would appear to be quite concerning, but that's only concerning if the false positive rate is 0.1%. And we can get some sort of idea on what the false positive rate is by looking at the maximum positivity rate on a given day when lots of samples were tested. And for example, in Ireland, which uses very similar technology to what is used in the UK, over the summer of 2020, they reported 12 positives in 187,000 samples over a period of time. So that gives you a positivity rate of 0.0064%, which is pretty good. Now that's the maximum possible false positive rate, and those 12 might have all been positive for all we know. We also know that in Wuhan, the entire city was tested by PCR. That's 11 million people. They found 300 positives, and that would give a maximum possible false positive rate of 0.00028%. So these two scenarios give a false positive rate way lower than that was postulated by Hennigan in that rather alarming article that you have just read. Now the current best estimate for the UK is probably somewhere between these two values here. So using this data, even using the Ireland data, if you were to apply that to the UK, even when the prevalence was incredibly low, such as over the summer of 2020, where the rate was about 1 in 1,000 in the population, a positive result is 15 times more likely to be a true positive than a false positive. And that's using the Ireland data. So therefore, although this idea of false positive gained a lot of traction, and a lot of people were claiming that there was going to be a false positive case pandemic where the vast majority of people who were testing positive were not actually positive, I think when you actually bother to dig down into the data and identify the most likely false positive rate, you'll find that that was probably not such a concern after all. So then you can work through various other scenarios and work out, you can now work out for any given positivity rate within a population and any given false positive rate, you should now be able to work out what proportion of test results that are given out are correct. So for that you need the positivity background rate in the population, you need the test sensitivity and the test specificity. And we'll do some examples of that in our live tutorial. Now another phenomenon that was widely touted in the media was how many positives are due to remnant virus. So if you got infected with SARS-CoV-2, let's say over the summer, you had a hacking cough and infected lungs, and then you felt okay, but then went for a PCR test in October, is it feasible that in August you were positive, you got better, but you still have remnant bits of virus that you are coughing up out of your lungs and can return a positive test? And this is possible. Probably not a major contributor to positive tests, but it is certainly possible and something that contributes to the false positive rate. So the quantitative PCR tests that are performed are highly sensitive and highly specific. These primers can really only give a positive result if the viral genome is present and there is no contamination. And it seems like the overwhelming majority of false positives are coming from contamination issues where one sample is getting transferred into an adjacent sample. And there's a bit of a scandal about that a few months ago, showing samples, particularly samples that have got a lot of mucus in them that were quite sticky, and when you try to pipette that, you get strings of mucus spreading over the test plate, and one sample could contaminate an entire row of samples. We know specificity can be affected with some patients showing very low levels of virus that are not clinically relevant. You could argue about whether that's a false positive or not a false positive. It's maybe a false positive for disease, but not a biochemical false positive. Now everything we've been talking about is PCR based, but you have to remember that the lateral flow tests are antibody based. And antibody based tests always have a lower specificity and sensitivity. So that's why a lateral flow test positive result is confirmed with a PCR test. Now some of you will have seen in the news recently lots of people in the southwest of England had had lateral flow test positives, then sent off a PCR test, and then that PCR test was returning a negative result, and that seems to be down to some catastrophic failure in one particular private lab that was processing a lot of tests. So yes, whilst PCR is incredibly good while it's been done properly with the right controls and the right quality control steps in place, something disastrously has gone wrong with one particular lab, and that's resulted in possibly 40-odd thousand false negative results being given up. These are people who've had a positive lateral flow test, then performed PCR, and the PCR has come back negative. So when the PCR has been done properly, it's very, very good. Antibodies have a lower sensitivity because antibodies can cross-react with other viruses. So if you've had an infection with one coronavirus that's related but not identical to SARS-CoV-2, so for example, I'll come on to this in a moment, but there are various other coronaviruses that are in circulation in the UK. So you could have one of these, generate antibodies to one of these viruses, and then some of those antibodies can be present within you, and that could come up positive on an antibody test for SARS-CoV-2 infection. So you could get a false positive in that way. However, the lateral flow tests that most people are performing are actually for antigen, which is viral proteins. And the antibodies in the test strips are validated to not recognise any of the other coronaviruses that are in circulation. So they shouldn't give a false positive, but they occasionally do. So we think that the false positive rate of some of the lateral flow tests might be as high as 2%. So you can see that that's why it's really well worth trying to confirm any lateral flow test with a PCR test. Okay, so that's the end of part 1 of the session on sensitivity and specificity.